Thank you, Jonathan, and thank you, everybody, for coming here. I'm very excited to share with you a bit of this other aspect of my work, not so much the research, but this is closer to the clinical side. So I'm going to introduce you some aspects of the diagnosis and risk assessment in GIST. So diagnosis just means... Sorry? Oh, excuse me. Micro, is it better? All right, so I'm just going to discuss a little bit how we diagnose GIST, so how we know that a tumor is a GIST, and how we then assess how bad this GIST is. So does it matter? Yes, we know that GIST is a bit different to other tumors, and the more we learn about this, we became aware that every tumor is different. So even if this now I can illustrate with a slide from 2004 how GIST behaves different to other sarcomas in regard to the response to therapy, this is probably the same for any other sarcoma, and there's more and more subclassifications. So in GIST, we really want to identify this tumor. We want to know if a tumor is a GIST. Usually, GIST presents clinically during an endoscopic procedure or imaging procedure. Well, there's a variety of reasons how a GIST can be found. Maybe it bleeds or other things, but this is quite inspecific. A surgeon may take this out, or an endoscopist may take some tissue, a sample, to see and to analyze and realize what is this tumor. We then integrate many aspects of this lesion. We check what's the context, the clinical context, for how long this thing has been there, where is it located, and then we focus on how this tumor looks under the microscope. And this is my area of expertise. As Jonathan said, this is what we do as pathologists. We check the morphology of this tumor. So we process it in a certain way, we section the tumor, and we stain it with dyes that we have, and we can check the morphology of the tumor, the appearance of the tumor, right? Then we can do some stains, use some markers that are more or less specific for this tumor, and we can rule out some things and rule in a GIST. In this case, this is showing the expression of KIT. As you know, these tumors are characterized by expressing KIT, and we can identify this molecule. So the morphology is not as easy as it could seem. Different tumors have different appearances. Here, 3 of these tumors are GISTs and 1 is not. Actually, this up here is a liposarcoma. So you see there's substantial overlap in the morphology of this tumor, but we are learning what's the spectrum and which things look like a GIST and which things are not GISTs. So this is part of our work, and we complement this basic staining with markers. This is KIT staining, and also there's different patterns of KIT staining, from tumors that express KIT very strongly and diffusely, others that have these dots, others almost don't express KIT. All of these are GISTs. So we have to integrate all this information and understand if this tumor is really a GIST. What are the advances? This has been going on for like 10 years. What's new? Well, we continue identifying more variants and more morphologies of GIST. As an example, the pediatric type GISTs that we've been discussing the last couple of years, and you'll see later Katie Jenway is going to present a lot about the biology of these tumors. They can have some peculiar morphology, some specific appearances. We also develop new markers, DOG1, PKC theta, and others that help us distinguish better these tumors. Just a little example of one of these pediatric type GIST, this one happening in an adult. So you see this is very peculiar for us because it has different nodules, it goes very deep, and it's multinodular. It also tends to go to lymph nodes as opposed to other GISTs. So these are new things. Any questions, sorry? No, okay. So these are new things that we learn, we publish, and we discuss, and people are becoming more and more aware of the range of morphologies of GIST. This helps us to identify them better. What about the risk assessment? Well, all the risk assessment is based on the different options for treatment for GIST in different stages of the disease. As you know, there's a precursor lesion, then there's a localized GIST, a primary tumor, that can evolve into a metastatic disease, right? So the issue here is that when we have a localized GIST, we usually go directly to surgery. The surgeon takes this tumor out, and we want to know what are the chances of that tumor to recur or to come back or to metastasize somewhere else. Because then we may use drugs to prevent that from happening, or we would follow these patients differently. If a GIST is metastatic at presentation, we already know it's bad, right? So there's not that discussion. It's more about management and how we deal with the metastasis. But in the localized setting, we need to know what to do, if we need something else. Actually, in other tumors, this is not a problem. So if I have a lump on the breast, sometimes it's easy to say, oh, this is benign or this is malignant. A polyp in the colon is benign or malignant. But GIST is a bit different in the sense that sometimes it's very hard to tell if this tumor is completely benign, so we cannot worry about it at all, or it actually has potential to metastasize. Usually the extremes are a bit easy to identify, but something in between is not so easy. So we use a system of risk stratification, where we just try to count variables or to summarize things to know if the GST is going to come back with which likelihood, which is the probability. Very low risk, intermediate, or high risk, right? So we have here some graphs, and you'll see many of these graphs today, where we show time here, and here the percentage of a group of patients, a big group of patients, and how long it takes for them to show again with some new disease or new manifestation of the disease. You see that very high-risk tumors recur early in time, 1 year, 2 years. Low-risk, very low-risk tumors don't recur or in long time, right? So this is the risk stratification system. We try to categorize the tumors. What do we use to do this? We use the size of the tumor. In general, a bigger tumor is worse than a smaller tumor, and that makes sense. We use mitotic count. Mitosis is something in the microscope, under the microscope, that we see and reflects the cells that are dividing. So we see figures like this. You see it looks like a little spider or something, or like a little worm type of thing here. These are cells that are dividing. So we can count under the microscope how many of these we see in a given surface of the tumor. That's the mitotic count. And it reflects just the proliferation, how fast the tumor is growing. And also the site of the tumor is important, if the tumor is gastric or not, if it's not gastric, small bowel versus other locations. So with all these variables, we can classify these tumors. And we use these variables like a tumor more than 5 centimeters, less than 5 centimeters, between 5 and 10 centimeters, or more than 10 centimeters. They do differently. A group of patients with those tumors behave differently in time. Same thing with mitosis, less than 5 mitosis, more or equal than 5. And same thing with the location. Stomach, small intestine, colon. So these are ways to classify these tumors and try to predict how they're going to behave. And we have tables like this where you count the mitosis of the tumor, the size, and then you assign a risk. This is the likelihood of the tumor coming back or not, and then we make therapeutic decisions on this. Maybe we have to give imatinib or not, etc. This is becoming more and more important as we have better drugs and newer drugs. We just want to classify the patients and know who needs which drug. So we are just trying to tailor the treatment as best as we can and don't risk treatments that are unnecessary. You see here exactly why this can be a bit problematic. We have a tumor with less than 5 mitosis and less than 5 centimeters with low risk, if it's in the small bowel, for example, but just 1 centimeter more, it becomes a high-risk tumor. So it's obvious that these categories, it's a good way to study big groups, but for a given patient, it may be a bit arbitrary. It's better 5.1 centimeters. That does mean that the tumor is much worse than not. So there's been some improvement here trying to improve this estimation of the tumor size and the mitotic count. So different studies have shown that, of course, these are not big categories. The 5 centimeters, 10 centimeters are not a real division, but there's a much more continuous distribution. It's worse 3 centimeters than 2, and 2 than 1. And that's, so we're trying to assess these variables in a more continuous way. Instead of less than 5 mitosis, more than 5, well, 1, 2, 3, 4, 5, 6, each number give a risk assessment for that. So some people have done this giving points or scores to different mutations. That's what is called a nomogram. Some of you may have known about that. So you try to count all the variables and go to a scale and give a percentage. Others, more visually oriented, may like these graphs where you just have here mitosis, tumor size, and you check where your particular tumor falls, and then you check the percentage of risk that you have, right? We can incorporate there more things that are still under investigation. For example, the type of KIT and PDGFR alpha mutation, or also the presence or absence of tumor rupture during surgery. So the mutations, we've known for long that they are relevant. Different mutations behave a bit different, but it's hard to get enough numbers to do studies that inform us about this. And also there's a lot of confounding factors here with the response to treatment. So this is still not yet there in the classification systems, in the risk assessment systems, but it could be potentially. Tumor rupture, however, seems to be quite predictive. So when there's, in surgery, maybe Dr. Raut is going to talk about this later, when there's ruptures of the tumor during surgery, this predicts early recurrence, and we know that. So we can incorporate this to these graphics and have location up here, gastric, non-gastric, rupture or no rupture, and then we come up with different graphs. These are just systems trying to predict as best as possible the risk of recurrence. Does this work? Well, a little bit. If we use continuous variables for the tumor size, continuous variables for the mitosis, and we incorporate these other variables, we get a better separation. So we know that if a tumor falls in this category here, if a patient has a tumor that falls in this category, we need to be more aggressive with our treatment. And maybe these patients we have to follow up with a bit less aggressive treatments and more. Anyway, so that's what I wanted to tell you. I think we are improving continuously the diagnosis. A big part of this is increasing the awareness of people about GIST, so more people know what is GIST and how to identify it and how it can be sometimes tricky, the morphology, not always typical. We have good markers to do this, so diagnosis is quite good and should be reproducible. And the risk stratification, we keep improving it continuously, so probably there's going to be more and more bigger studies that will allow us to classify better the tumors. That's it, and I just want to thank you for being here. And this is a picture from the last GIST walk. That is the first one I've missed since I'm in the States, and I hope I can go. This is in New York this fall. These are all my lab mates. Thank you very much.
So, although we want questions, we also want to stay on time. So this is really more a reminder for our presenters. Go pretty quickly so that we save a little bit of time for discussion and for questions. But with that in mind, and is there a quick question before we want to make sure we don't impinge on Dr. Raut's talk, which comes next, advances in surgery for GIST and sarcomas. But are there any quick questions about classification and risk assignment for GIST? I have one that perhaps we can come back to in future talks, which is that Adrian has shown us some of the things that are standard, and then some of the things that are a bit newer in the way of trying to predict for a given patient who has surgery, what is the risk of recurrence? And what I would like, but I'm not going to ask it for you now, Adrian, maybe Chan is good at yours, is for somebody who was diagnosed 4 years ago, do we need to revisit things as new information comes along? You know, is this really what we're talking about more for people who are diagnosed now, or should we be going back continually